Thank you very much. Hope you can all hear me. I'm just about to start the presentation. And unfortunately, as you know, I won't be able to see anything, but Liz and Hadj are going to manage the questions in the chat.
We will do.
So just bear with me. I've got a problem with my mouse straight away, which is not helpful. Right, okay, then we will start. So as Liz has said, I am Bridgett Welsh. I'm a nurse background. I've been a nurse for 45 years, and I am one of the specialist safeguarding practitioners in the ICB safeguarding team. So what we're going to talk about today is let's just have a little bit of a think straight off around what we're talking about in terms of restrictive practices. And I know that a lot of you are really familiar with this, so I apologise if we're going over some old ground just on this first few slides, but it's just to get us into that space where those who might not truly understand what a restrictive practice is can start to think about the extent of what it is. So in terms of this slide, this is sort of like just for us to think about and for you to think about and focus on what we're seeing here. Restrictive practices are quite extensive. And we'll talk about the definition, or we'll talk about what it means to different people. But as you can see just from the slide, it can include anything from injectable, tranquilization. It could be closing a door. It could be any barrier. It might be medication. It could be locks. It could just be placing your hand on somebody. And we'll talk about what that is and what we're talking about in the next couple of slides. What I found was interesting when I was doing some of this work was Signet Healthcare did a little bit of research with their staff, and they undertook a staff questionnaire. And what they asked the staff is what was their understanding of restrictive practice. And when you look at this slide, it's really interesting, really, in terms of some of the language that's used and people's understanding. So to some people, it was about following rules. A lot of people talked about restraint straight away as restrictive practice being something physical. When a person's rights or freedoms are controlled, yeah, I can see that. But then you can see here, there is some interesting use of words in here. So a form of managing behaviour deemed risky by who and to whom. And that result in certain privileges that are lost. And I thought that word privilege was interesting, really, in terms of the concept of what it is. But other people talked about when you don't allow patients to do things. Some people had heard of the use of the term restrictive practice, but couldn't really remember what was meant by that. Some people talked about rules. Where's that one? Oh, I said about following rules, practicing within limits. Some really, really interesting feedback. I won't go through them all, but I just wanted to highlight right at the beginning that people's perception of what a restrictive practice is always different, and some very interesting use of the word and if we are coming from a really trauma-informed place, some of the wording we should be really challenging. So in terms of what and why is restrictive practice, there are a number of definitions. There are a number of the evidence base, and the national evidence base talks about restrictive practices in many different ways. But I thought these were quite interesting in terms of it being any practice or intervention that restricts rights or freedom of movement of a person. And that's really what we're talking about, rights and freedoms. And it can result in little choice or control in somebody's lives. Restrictive practices are deliberate acts on the part of another person that therefore restricts a patient's movement, their liberty, their freedom to act independently. However, there are times when we will use a restrictive practice if it is in order to keep somebody safe, if it's based upon risk, or to keep others safe. And there is an absolute and utter need to take immediate control of a very dangerous situation where there's a possibility of real harm to others. And if no other course of action can be taken, then we must be intervening to end or reduce the danger to that patient or others. Restrictive practices could be making somebody do something they don't want to do, or stopping them doing something that they want to do. And you can see on the slide here, when you look at some of the guidance CQC produces for us, it talks about reducing restrictive practices has to be everybody's responsibility, because the last thing we want to do is take away somebody's liberty, to remove their freedom and to exercise control, and remove somebody's choice in what's happening in their daily lives and how their care is being managed. And every person has a right to be treated with respect and dignity, and to have their needs supported and given the right support based upon their wishes and their wants. So what happened? Some of you might already be aware of this project. So this was something that we were seeing in, well, it was the CCGs at the time, and then we moved in to become the ICBs. And we were seeing an increased number of incidents, and serious incidents, that included the use of medication, over sedation, and medication being used as a way of perhaps controlling somebody's behaviour. We were seeing increased incidents of assaults on staff and patients, and we were also seeing through our safeguarding adult reviews, we were seeing a number of incidents whereby patients were being assaulted by other patients, and incidents of violence and aggression within care settings. So my involvement was around, from a safeguarding point of view, we really need to keep these people safe. We need to find out what is the learning from these reviews and what steps can we take to really look into this. And I'd worked in LSCFT before, mental health services, and I'd heard of this guy, Paul Greenwood, who actually is an absolute legend from Aqua. And he'd done some work with mental health services around reducing the use of restrictive practices to support care. So we sourced financial support from the Safeguarding Adults Board. So I'd like to acknowledge their support right from the beginning, and the fact that they saw this as it was quite a serious safeguarding issue that we needed to look into and to strengthen our practice around. So ourselves in the ICB, our colleagues in Aqua and the Safeguarding Board, we met with colleagues in the local authority, and we set up a little working group to look at what were our aims and our plans. And what did we do? Well, we generated a plan on a page, and that involved us working with 2 large homes where we'd seen significant numbers of incidents. And there might be people, I'm not going to be naming the homes, but I mean, I can't thank them enough for their involvement in the project and some of the fantastic work that they did. And they were across dementia nursing settings and dementia settings. Some of the process involved some learning events, and Paul delivered learning events based upon least restrictive practice, what it was, and really went into the depth of that. What were the homes seeing? What were those incidents? Throughout the project, we came from a real trauma-informed place. So what was it that made that person the person they were? And what was that person like before they became unwell, or before they had supported needs, or before they had increased vulnerability? And we came from a really personalised approach to care, and I'll talk you through that a little bit further on. The events consisted of face-to-face improvement sessions and a lot of coaching, and Paul sat with the teams, and it was really about engagement with the teams at every single level, not just management, but about engaging with every single level. And we looked at some of the data that was out there that told us, and some of the evidence base that talked about best practice in relation to this area. And what things could help the teams to identify and map some of the patterns and trends that they were seeing within the settings they were working in. We really wanted it to come from the staff. The changes and the improvement plans came from the staff, and that's to be really celebrated. We wanted the staff to identify and test out, come up with the solutions and allow them to test it out, because it's okay if you test something out as an improvement and then you notice it's not working, then it's okay to stop that and change it, isn't it? And this same work was being carried out simultaneously in another home in Preston, and they themselves paid for Aqua to come in to do some of the improvement work. So the plan, what did it look like? The aim was ultimately, we knew that we would not stop every single restrictive practice, and there was a lot of education that had to be involved. So our goal was to reduce those restrictive practices within the 12-month period by 25%. And we thought that would be quite achievable. And the way that we did it is, you can see in the top box in the grey, I'll show you what the heat maps and safety crosses look like, but we started to capture the data, and our colleagues in the local authority were able to give Paul live information around incidents and what was being seen around safeguarding, alerts being raised at that time that were linked to what we're discussing. We looked very much at the environment, and the project involved a lot of walkarounds in the homes and observations of staff, observations of patients. We took, as I've said already, it involved coming from a real person-placed centre of care. It involved a trauma-informed approach to care, and we very much looked at triggers, warning signs, what the staff might be picking up in terms of the residents, and linking that to their behaviour that was seen. Okay. So this just shows you the teams collected data via these safety crosses. So you can see the safety cross there on the left-hand side. Quite an effective way of capturing real-time data. So what the staff did, those numbers on the cross are all the days of the calendar month. So they would just put a little mark on that date, so we could see, you know, what days, what dates were these incidents happening. And the staff placed these in a prominent position, so it was like live information, if you like, that helped to identify patterns and trends. They were put on the notice board in maybe the staff room, and if nothing else, it generated curiosity, and staff were asking about, you know, what's that, what does that mean, and it really, you know, staff started to be interested in what the data was telling them and to own it as well. If you look on the right hand side, the heat map, this was just, Paul encouraged the homes to download their basic fire evacuation plan, if you like, and have a look at that. But as the incidents were taking place, looking at where were these incidents happening. So, for example, were they down a particular corridor, or near a particular door, or were they in the restroom, were they in the bathrooms, were they in the lounge or the dining rooms, etc. And the same work was carried out across each of the homes that we looked at. And the use of these heat maps and safety crosses, it helped improve staff's understanding of real-time information, but it gave them something visual that the team could respond to. And it really started to become apparent the importance of the environment then, and how adapting the environment could support residents. And what came out, there was 6 areas that were a real focus of the work, that 6 key areas emerged as times when and occasions when incidents were happening. And those were these 6 that you can see on the screen. During personal care, so that might be in the morning, during, you know, when a patient was getting up or having a shower, a bath, etc., getting dressed. At meal times, when people were coming together and there was a bit of a flurry of activity and lots of people in the same space at the same time. During observations, so that might be if somebody was on constant view observations, or even, you know, walking with somebody, if somebody was walking with purpose. We did observe staff who were observing those patients, and they were walking, for example, right on the elbow of a patient. Now, I just sort of like looked at that. There was no interaction. There was no verbal conversation between the patient and the staff member doing the observations. And I thought, well, actually, that would be quite irritating to me if somebody was following me around all day on my elbow, not talking to me, not having a conversation with me. I get irritated. at the time of new admissions. So a lot of patients were coming in, it was dark, it might be wet, they're coming into a strange environment on an ambulance, placed flat on a stretcher, they don't know where they are. How scary must that be for somebody? And so we focused on that area. There was also obviously the added the specifics around individual residents, and that really being individual and having an individual focus on complexity and who and what that resident made that resident the person they were. And then we looked at environmental changes. And these are the six areas that emerged as key points. And this slide just illustrates, I'll just give you a couple of examples that Paul identified in some of the homes. So in relation to this resident, as we've just been saying, this resident was on enhanced OBS due to aggressive behaviour. And when they noticed on the heat maps that it happened in a particular area, and all that involved, what struck me the most in this model that we did was the simple changes made such a massive difference to the residents' behaviour, to the patient's behaviour. And all that required was staff adjusting themselves, their position around that individual or their seating area, not being too close. They could still observe and be within reach, but it was about just placing yourselves differently around the patient. So the patient's not lashing out or feeling trapped if they've got somebody walking with them down a really narrow part of the corridor with a low roof. And the outcome immediately, staff captured the outcome in terms of incidents dropping dramatically just by that really, really small, simple thing of moving staff and placing staff in different places. And over a period of time, that residents' level of observations moving right down. So there wasn't that need for intervention, etc. Meal times, again, this incident and staff particularly focused on one resident who was agitated at meal times. And this was really, really interesting. And we did smile about this because this patient was an ex-prison officer. And at meal times, he'd go around and he'd try locking the doors when there was, others were out. And if he was stopped locking the doors, he might get a little bit angry about being stopped or unhappy, let me say, about being stopped. But what the staff did, they worked with him to help him complete this task rather than stopping him doing that. It was, well, this is something he wants to do, so let's make it safe for him to do it. And then they would invite him to go on a break because that was his pattern when he was working as an officer. He would lock the doors and then he would go and have a little break, maybe himself, and that would be in a quiet area, which is where he used to go when he was working. He would go to the staff room or wherever. But by enabling that resident with staff support to complete their task, offering that break time, it led to, again, a reduction in some of the challenging behaviours that they faced from him. Again, really simplistic, personalised approach. Mapping of personal care to help staff better understand the process and its impact was something that really struck me. It really was probably the most apparent thing really for me that I hooked onto was this need for such personalised, considerate care. There was some examples here that talked about mealtime improvement. So in one of the homes, they just literally moved some of the tables around. So you hadn't got a big lump of tables, if you like, in one place. They were more spread out. Patients had more space. And just again, that little approach, allowing patients to maybe, have a little table maybe somewhere down an end of a corridor in a quiet area if they didn't want to eat in the main dining room. The use of alternative environments really had an impact on some of the behaviours, the behaviours that challenge us at meal times. I've just skipped on a little bit quickly there. So this focus and the discussion very quickly led to suggestions around improvement, but suggestions based around the importance of personalised care and that recognition of the individual as a person themselves. The other thing that came out was the importance of structure. So that really having structure throughout somebody's day, whether it was through activities, jigsaws, cards, art, whatever it might be. Encouraging the patients to even like set the tables at meal times. All of those sorts of things made a big difference in reducing the incidence. And there was a big, as I say, shift in thinking to that real personalized approach, and keeping it personal and keeping it real. And this slide, I've just tried to share with you some of the additional suggestions that staff came up with. So having increased sensory resources, and training for staff on that sensory modulation and how to use that. Some other examples there, again, that focus on trauma-informed approaches and making sure staff were trained around that. The use of things like weighted blankets, maybe for comfort for somebody, if that's what they were looking for. Headphones, letting that individual have some headphones that played their favorite music. That might have been a bit of a diversionary tactic for that individual. Meal times being managed on a more personal basis. One of the homes that we particularly looked at developing protocols with, and the focus, they came from a place of saying, what would a great admission look like? So not what a poor admission look like, what was the challenges they were seeing, not what was the challenges they were seeing, but if we were admitting a patient, what would a great admission look like? And that great admission led to some little changes, such as staff going outside to greet the ambulance in the car park, greet the patient in the car park. Hi, I'm Bridgett, and welcome to this place. Here's a cushion. Let's put this behind your head, get you comfy. Shall we sit you up a bit? Do you want another blanket? Other staff being placed at the doors so that the patients going in, as they're going through the doors at the point of admission, they're not banging to behind them. They're not hearing all these strange noises. Staff did a lot of preparation work around admission and making sure that there was patients' belongings there and in the room ready for that patient, not them coming afterwards. So there was a lot of familiarity in the room as well. And those little things really made a difference at the point of admission. On this slide, I've just put a link to a YouTube video. You will be sent the slides, and it might be something that you might want to watch this. I think it's about 10 minutes long, but it's really good, and I'd encourage you to do that. We haven't got time to watch it today, but please take this away and have a little click on that. And it just reinforces a lot of the things that we've been talking about in terms of approach. So the biggest, most powerful and the most human factor in all of this that really struck my thinking was, as I've already said, was about who that person actually is. It's probably the most obvious thing that you can think of, but it's also the most impactful in terms of understanding why somebody behaves the way that they do, and might challenge carers in the way that they do. And one of the most important things in this approach rested on the understanding of who that person was, what made them the person they were, what was their job, what was the community that they lived in, what was their potential as a person, did they reach their full potential, or their wishes and wants, were they being thought about to encourage that individual to reach their full potential, both in terms of their well-being, their care and their physicality, their movement and ability to get about. Personalised care represents True personalised care represents a new relationship between people, professionals, and the health and healthcare system. And if you look, although for some of you, personalised care, and for myself, is something that I've talked about for years and years and years, if you look in things like the 10-year health plan that's just coming out, it talks very much about a shift and a real emphasis on personalising our approaches to care. And I put you, as I say, some links in there, one to the NHS long-term plan, which might be of interest to you, but again to that YouTube video. And what we talked about when we were talking about personhood was that importance of recognizing somebody's behavior that might challenge as a form of communication. People behave in that way. They might not be able to communicate their needs, but behavior is an absolute crucial form of communication. Who is that person in there? They are still a person, even though a person might have a diagnosis or an illness of dementia, Alzheimer's, etc. They are still a person in there. What makes that person the person they are? What were their life experiences? What was childhood like? What were their family relationships like? Their jobs, their home, their family? Who still comes to visit them? And this really leads to a person being recognized by others as still being a person. I just wanted to sort of like, some of you will be aware of Kitwood and the work that Tom Kitwood did. This goes back to the 1980s, and you might think, well, that's really old research. But for those of you who haven't read Kitwood, I'd really encourage you to get this book. And the book's been updated and reviewed. Sadly, Tom Kitwood died, but his work and his thinking around person-centered care are so valuable. And what he does is he emphasizes, I got this image off the Dementia Hub website. So have a look on there as well, because they too support the psychological needs of that person living with dementia. And there you can see Kitwood and his thinking that talks about us all needing comfort, all of us needing identity, all of us to have that thinking around occupation and maintaining that involvement in some way, in a form of activity that draws on the person's abilities and their skills that they've had throughout their life. The need for inclusion, the need to belong in a group. And we are all social beings, and we have an inherent need to have social interaction with others. And that attachment, the need to have attachment and special bonds with people. Person-centered care is a way of thinking about a person living with dementia and how to support them to enhance their quality of life. At the center of all of that, you can see in the middle is something about love. So how, not deep, maybe intimate love, not that sort of thing that we're talking about, but in that professional relationship between yourself and the patient or the resident, it's that sense of being cared for, being a valuable person, and having somebody that's genuinely interested in you. And it's sometimes difficult for us, isn't it, to understand why a person behaves in the way that they do or make the decisions that they make. But if we are seeing that person living with dementia as a person who is still valuable to society, to us, to themselves and to their families, they have a unique history. They have their own routines, their own personal preferences. They might not like a shower in the morning. They might want a bath. They might want to be asked about what choice of clothes that they wear in the morning. They might not want to wear pop socks and a skirt. They might want to wear, trousers or a tracksuit. Let's give those people those personal preferences. Just those little things make such a difference in terms of inclusion, identity, and supporting somebody's behavior as well. And this, I mean, for a lot of people, this could be challenging for people to come from that approach, because it does take people away from that centralized and older medical model of care, which has often in the past seen people as a diagnosis rather than that still a valuable, meaningful, living, breathing person that has their own unique needs, history, etc. And this was really powerful for people. So I just wanted to think about this person. Let me see if it works. It's not worked already because that's come up. So in terms of what we're thinking about, I'm just thinking and how we are thinking as individuals. The question I'm asking us today is, when we think about Batman, was Batman a person? He was different. He had superpowers. what made him unique. So if you're thinking just in your own head now, think about what made Batman unique. Here he is. Well, certainly his clothing. He chose that, and that's what he wore. And for certain times in certain times of his days. He sadly he lost his parents, didn't he, when he was a child? And for Batman, that was profoundly shaped him and who he was. The death of his parents, the murder of his parents, profoundly shaped him, and it fueled his vigilantism, didn't it? The trauma he experienced from the murder of his parents at a young age caused him to have arguably some psychological trauma, possibly some PTSD, do you think? And you could certainly pick up in the films, certainly the more modern films, the impact on his mood and possible depression. He was very isolated. He made a choice of a solitary vigilante life that led to immense loneliness and emotional torment. And he had a constant struggle, didn't he? You could argue that some of that severe physical and psychological pain through his crime fighting could have been, it took a considerable toll on him, didn't it? And almost to the point of it becoming self-injurious and self-harm. But for those people that knew him, who really knew who he was and who were about him, Alfred, Robin, Batgirl, he meant a lot to them. And yeah, he was a person to them. He remained a person to them. Especially to Alfred. Alfred's care was crucial to Batman. And if we're thinking ourselves with an individual who is different, who maybe has his own superpowers or differences in some ways, Alfred's care, and that could equate to any one of us, was crucial to Batman's life. He was his caregiver. He was his paternal figure. He provided him with physical and emotional support. He helped him with his training. He cooked for him. He was a butler to him, and he was a surrogate father to him. And his influence shaped that individual and some of his behaviours, and it gave him a lot. It offered him a moral compass. He was an advocate. He was a grounding presence, and he helped Batman managing the practicalities of his life and needs. I'm just trying to give you an example, a bizarre example, I know, of the impact that you as individuals and carers and teams can have on an individual's life. And what that led to in the end, and it's the same with that personalised approach to care, it creates stronger relationships between the patient and the carer, and a higher satisfaction for both the patient and the carers around that individual. And person-centered care has been associated with many positive outcomes of care. When you read about person-centered care, it talks about an improvement in the patient's emotional state, the satisfaction and empowerment for both the patient and for the staff as well. It reduces incidents, it can reduce complaints, and it can only lead to nothing but satisfaction for both the carer and for the patient as well. And the importance in those relationships is so significant, isn't it? I found this quote by Professor Tom Kitwood, and I thought it was really quite hard-hitting in a way. It really resonated with myself. Treating the person living with dementia as if they're no longer a person, as if they'd lost personhood, exacerbates the impact and the progression of the dementia. Something for us to think about. You know, we then begin to cause harm if we don't come from this person-centered, trauma-informed place. Another little link in there for you. There is a 7-minute briefing that the Safeguarding Adults Board produced that I helped support them with after we've completed this piece of work, and that talks about why it matters having these positive pathways and this approach to reduce restrictive practices. The links on there, which you will have, and it's something that you could take to your team meetings, just have a chat about what do people think about this, and what do you need to do about that within your work settings. And then these last slides just start to illustrate some of the impact. So what was the impact that these homes were seeing in terms, and what was the success of the project? And you can see it was quite stark. One of the care homes saw a reduction in incidence of approximately 40% within the time of a 6-month program, not 12 months, 6 months. The second care home saw 50% of teams showing a reduction in incidence. This spoke volumes to us. It absolutely, and it told us it was the right thing to do. And we've got the evidence base there that this approach works now. One of the care homes saw an improvement in retention of staff as well. Staff felt more involved, more engaged in some of the decision making around the patients and the way that the teams were working. And throughout this, one of the important things that we talked about at every steering group meeting was, were there any risks being identified along the way? And at no point were there any clinical risks identified in terms of some of the changes that staff were making. So in terms of the project, sadly, the funding stream came to an end and we weren't able to sustain financially and roll out this model. But we absolutely want to share with everybody far and wide the impact of some of this work and what it had on the care system. We saw a step down in acuity. So some patients who've been on a CBU unit, you know, their levels of nursing need greatly stepped down. And that therefore had financial benefits for the system. Maybe that should be down at the bottom actually. But because the impact that was greatest was the patient really and the patient's safety. We saw an increase in least restrictive practices, observation levels reduced, meal times better managed, a reduction in benzodiazepine use as a form of control and managing somebody's behaviour, PRM medication being drawn out much too quickly. We saw a great reduction in that. We saw environmental changes, the difference that a lick of paint made to an environment that sort of like broke up those long corridors just by changing the colour on a wall and placing a little table or some chairs in a strategically placed safe space. We saw a reduction in safeguarding incidents and other incidents as well. So what next for us? There's just us really encouraging the system really to have plans and discussions in place to maintain this sustainability. And I was so chuffed when Adele and Liz and the team came and said, Bridgett, will you share some of this with at this opportunity? I so believe in what we did was the right thing to do, and I saw the results. I saw the results directly. So I just want to talk about this and share this from the rooftops really. We need to look at how we use this work to influence other things that we have in place, to influence radar, for example, where we go and we talk about the challenges that we're seeing. We've certainly got, I mean, our quality team and Liz's team certainly out there now taking and driving this focus in terms of care and delivery of care and the quality of care. And for us, the SAF processes, the Safeguarding Assurance Framework processes. So for us in the safeguarding world, really looking at this approach when we're out there and we're doing our visits in terms of safeguarding and supporting homes, practices, etc., that we're coming from this trauma-informed, patient-centered place. Okay. So just in terms of yourselves, I just want you to think about as you leave today, you know, what are these things that you could do in your place of work? Take yourself to your place of work. There is no one size fits all strategy to this, but think about how this approach can work in the setting that you're working in. There are lots of different models out there that share characteristics of good practice. Definitely they share a positive cultural shift to least restrictive practices. So think about that, about the culture in your setting. What is that like in the place that you work, in your approach to restrictive practices and that application of least restriction in somebody's life? think about what training do you need for your role? What would help you in truly understand the causes of violence and aggression? And some of the, I think your first session in particular that you've had here, and the session with Rosie and a colleague last week, will maybe generate some thinking and give you some of the, increase your understanding of the causes of violence and aggression and challenge and behaviours that challenge. Think about that in terms of you personally. What do you need more to be able to do your role and understand this a little bit more? And also think about how you include the patient and the family in their care. Do you really, in your care settings, can you do anything a little bit more inclusively for that family and for that person who's living with dementia? Can you understand a little bit more about what that person's life was like and what their wishes and wants and needs are? So really, over to you. You can make this happen. You can be part of a team that strives for outstanding and good in terms of quality care. I was looking at this before I did this presentation around Lancashire care homes, and I think I only found one on the CQC website that had been graded outstanding. I know that there's a lot of people out there that want to go down this route and want to enhance the well-being of persons living with dementia, and all of you can move to that level. Attitude was a big thing that struck me with this project, and it made a big difference. Person-centered care we've talked about, and just that thinking in your teams that those little things can add up to make a big difference to the patient's life. And think about that patient in terms what matters to them, what makes their day, what will make their day easier, what will help them in terms of managing their behaviours and being the person that they've always wanted to be, and maintaining that person that they have been. Outstanding care homes work well with multidisciplinary teams from the community. So making sure you've got that connection with your multidisciplinary partners as well. And the whole aim there is to provide that best care for residents. Outstanding care homes do have outstanding managers and staff, and they have outstanding managers that are visible in day-to-day running of the organisation. And all those staff working in those outstanding care homes are committed to providing high quality care for their residents, whatever the challenges may be. And they're so proud of that. And you're so proud of that, I know, in your daily work. The care homes that have outstanding managers support the development of that enabling culture and that collective leadership that's really inclusive of all staff. So have that thinking as well. Outstanding care homes motivate their staff and develop their staff. That's very much evident, and that was evident in these care homes we work with. They supported initiatives such as this to be part of their change programme and part of their delivery of care, and they were so keen to get it right and improve the outcomes for the patients, but also the staff as well, that the staff felt more involved and more engaged and more included in care. They motivated their staff, which gave them a degree of independence to make some decisions as needed based upon the wishes and wants of that individual. Some of the changes could be done quickly. Some changes involve long-term, don't they, and a lot of sustainability and a lot of help from others as well. So you're not going to be able to do everything, but just think about those little things that you can do, those little things that can add up to make a difference. And this is safeguarding in the widest possible sense. I'm going to end the slideshow there, and I'm going to shut up. I hope I've stuck to time. I think I might have just gone a little minute over. I'm going to stop sharing.
That was fantastic, Bridgett. Thank you so much.
So,
absolutely brilliant, and great to hear of all the work that went on. Does anybody have any questions or ideas that they'd like to raise with the group?
Everyone's going to go quiet now.
I did see a clapping hand emoji there. Thank you so much, Bridget.
Thank you. Thank you. It's not hard. It was really powerful to be involved with, and I'm so privileged to have been involved with it, because you could just see some of the light bulb moments. You could just see when we were walking through some of the units, you know, for example, like a corridor at the end that had a door, an exit door. Well, everybody's going to walk to an exit door. And what that led to was about 6 residents in one small confined area that was really frustrating for those residents. So thank you. Oh, Angela's put a comment in there. The Batman analogy.
That was fabulous.
I had to think of the most bizarre, different person. But thank you very much for your time, everybody. I hope it's been of use to people.
Just before we let you go, does anybody have any questions or any suggestions of things that they've made, changes that they've made in their organisations, maybe? What's been helpful? Anything that you'd like to share as well with Bridget and everybody else? That would be really helpful. Angela, I see you've got your hand up there.
I'm going to be a complete nerd on you, Bridget, just for your future presentations, because Batman doesn't have superpowers. He doesn't. That's the whole point. He's a normal person. You know, he's full of strength and he's got a drive and he's got a lot of money and equipment, but, you know, he's just a normal person. So.
But he was perceived to have superpowers, wasn't he?
I'll give you that.
Obviously.
Yeah. But I loved it.
I've just seen the comment around that you're putting around the number of CQC outstanding care homes across the ICB footprint. That's awesome, isn't it? Yeah, but honestly, they might not be showing on the ratings at the moment, but it would be great for us to celebrate that, wouldn't it? And you know that we have got those outstanding places.
We do. Yeah,
absolutely.
And many that the CQC haven't come back to as well. So that's a quite true.
Absolutely.
Yeah. Well done. It was brilliant. Thank you.
Oh, thanks, Angela.
We have got lots of thanks in the chat. Any questions or anything from anybody? Everybody's gone very quiet again.
We'll send that presentation out, won't we?
Yeah, absolutely. Hadj, if you want to stop recording, and then I'll just share with everybody the next sessions that we've got.